In these two chapters, we're looking at why you're going into the profession of radiologic technology and what qualities you need to work in the field. Things that might help you navigate and learn the skills needed for excellent patient care, which is what our goal with this class and with this whole program is excellent patient care. Radiology is a hands-on, people-oriented profession with, of course, added layers of illness, discomfort, and fear in our patients. It's critical that we're able to communicate clearly and with the utmost respect and caring, because our patients know that, they recognize that, and they see it in us and feel it from us. And getting that most accurate information from our patients for our radiologist is a really great skill that you can learn. Some of you probably already have it naturally, but some of us it's not as natural, and takes a little time to make sure you know which questions to ask and how to ask them and how to approach people. So you're going to learn that definitely in the clinic when you're out there. And you have to remember communicating with the patient as well as their families is a priority in most of the hospitals now. So think about what happens to a patient when they enter a hospital. First of all, they're sick enough that they need help, and that's why they're there. They come in, and one of the first things that we ask them to do is to take off their clothes. They're afraid and emotional. You never know how somebody's going to react to being touched or even talked to. They're just not themselves when they're sick. Think about how you feel when you're sick. This is why you need to figure out why you're here. What are you doing here? And how are you going to communicate with your patients? So what are your personal needs as a technologist? What do you want out of this? You want to help others? You want to work with people? You want to make a difference? Those are all things that most of us have in common. It's not just about getting a good job that pays really well, because you can do other things that aren't patient related. But for a lot of us in the healthcare profession, we really want to help people and we want to make a difference in somebody's life. So what does it mean to have your personal needs met so you can feel confident in your abilities? If you're well rested and you feel safe in your learning environment, have the patient's best interest first and foremost, and are respectful and considerate, your patients will have the confidence in you and your abilities. They're going to see that you feel good about what you're doing and how you're doing it, and they're going to see that as confidence. So keep that in mind when you're learning. If you're unsettled because you're not sure what you're doing, then act like you know what you're doing. Fake it till you make it. A lot of times that really makes a difference in how your confidence comes across to people. There's the Maslow's hierarchy of human needs, and it talks about the different levels of where people are in self-actualization, or how, if they're comfortable in the way things are in their lives. So there are a lot of people who, when they come into the hospital, they are definitely at the lower end of Maslow's hierarchy, which means that they need their most basic needs to be met, and that would be food and shelter and clothing, and then they need to feel safe. A lot of times they're not quite there yet. They don't feel safe in a hospital environment that's really unfamiliar to them. Plus they're sick, so that's an added layer of just not comfortable. And patients handle these things so differently in so many different ways. You need to be flexible in your responses to them. In my experience with mammography, people will laugh or joke or cry, or they won't speak to you at all, or they can't shut up, or they watch your face so closely. They want to see what you're thinking and what they're imagining you see on their images, and that you know something and you're just not telling them. They watch like that because they're afraid. So you never know what they're going to say. One of the things that people said to me, this one woman said to me was, did you go to school for this? Because if you did, you must not have known what you were in for, or you just don't know any better because there are a lot of better jobs out there. So why would you say something like that to someone? I think it's more about they're so uncomfortable in the situation that they're in, they just don't know how to act or how to recognize what you're trying to do for them. They can only see what they're feeling inside, and they lash out at people, or they just don't understand when they say things like that. Um, as I said, currently hospitals are really focused on communication and patient satisfaction and productivity numbers, and a lot of that is all tied to reimbursement rates from hospitals for value and efficiency and all those things that you saw a lot of that in your hospital mission and values and goals and things like that. So one of the ways they're working on those things is to have patients be really satisfied. And if you communicate with patients and their families in a way that makes them feel you're focused on them, and they are important to you, and what they're going through right now is your priority, they're going to be a lot more satisfied and feel like they've been taken care of. And imagine if you write and speak and have electronic communication that's all very clear and to the point, how many fewer errors there are going to be in the healthcare environment in general. Communication essentials would be patient care communication is very patient focused, as I was just saying. It's got to be all about the patient because that's their priority right now, and it should be yours as well. You need to be accurate, and you need to work quickly and efficiently and get the information to the radiologist as needed. Always remember that when you're communicating, you have to relate with the patients and families and visitors, everybody. Um, and you have to communicate within your scope of practice. And scope of practice is on page 354 in your patient care book, and you all need to read it and recognize what you can appropriately say or not. So you have to follow hospital policies, you have to follow the guidelines in your department. You have to stay within what you are trained to do. So you're going to find that there's going to be 100 different ways you're going to learn how to say, no, I cannot tell you what I see on your x-ray. I don't read them. The radiologist will read them and get the results to your doctor. Your doctor's the best person to give you your results since you and your doctor work together in your healthcare. So find out a way to say that to make them understand that it's really not up to you to tell them their results. Sometimes it's hard and patients are going to pressure you. Come on, you can tell me. I won't tell anyone. You can just be really frank with them, you know? That's not my job. That's not my area of expertise. I can lose my job if I tell you anything. And if they say, I won't tell anyone, you just have to move on and say, I'm sorry, you need to talk to your doctor. It's not going to be easy. Sometimes you have to get creative and you have to really keep pushing to get out of that situation. And these are the different types of verbal communication: the spoken word, written words, voice intonation, slang and jargon. Be really careful when you're using slang and medical jargon because you don't know what that person's background may or may not be as far as understanding the words that you're using. So we'll get to that when we talk about patients or Americans in general, language understanding. You can use humor, and that's fine as long as it's used appropriately and it puts the patient at ease. But you're going to have to be really careful and learning which situations that's appropriate or not. You're going to work with some techs who are really good at it, and you're going to work with some techs who shouldn't be doing it. So you need to think about that when you're learning from the technologists out there at the clinics. And just be really judicious in how you use your humor in the hospital. Nonverbal communication. I've seen a lot of this when my kids were teenagers. Um, Body language is key, and sometimes it'll take some time for you to get used to reading people. And facial expressions are huge, and reactions to you are also important. You just have to recognize that. So always look them in the eye and try to be as professional as possible. Take care of your appearance, just like we were talking about for DCP, and be clean, don't smell, things like that patients are very sensitive to. Touching a patient, you really need to be careful that you touch them appropriately. And you're going to get a lot of that in your patient care lab or your positioning labs, so that you understand what's appropriate, making sure you warn the patient you're going to touch them. When you touch them, it's, as minimal as you can get away with to get what you need, things like that. Just be aware of patients' comfort level with being touched. And another thing to consider, and what I was talking about before, is what patients understand. The average American reads at an 8th to ninth grade level, and I think most newspapers are written at a 5th to 7th grade level. And 44% of people over 65 read at about a 5th grade level or lower. That is incredible to me. So you just have to understand that. Be clear with your words and use more simple words so that what you're saying is understandable by everyone, no matter who you're talking about or what level of reading they may or may not have. This is an example of what a 5th grade reading level is. So you can read this and see how it's not super elementary, but it's not expansive either. It's very simple and to the point, and I think that's not how you need to think about how you talk to your patients. These are common types of patients you're going to get. One of the things that I found really super helpful is using the Serophone well, that's what they have at Scripps. It's an interpreter's phone, so you can call on one handset and the other handset the patient has, and you can have a whole conversation in that patient's language so that they can understand what you're telling them about their healthcare or the history that you're trying to take from them. It is their right to understand what's going on in their healthcare at any given time. And even though people speak English, they may not be comfortable in that's not their first language. So you need to be sensitive to that and ask them if they want an interpreter, even though they can speak English with you, just to be sure that they're comfortable understanding their medical care in a language that's not maybe their first language. You'll likely see service animals that come in with patients. And yes, miniature horses can be service animals. And one article I read said that they're chosen a lot of times because they live so long, whereas dogs may only live 12 to 15 years. Miniature horses might live up to 35 years. So that's an animal that can be with you for a really long time and really be able to help you and be comfortable with you. See what else here. Also, there's sign language interpreters that you can use. Sometimes you have a computer where it's used like Skype, where they can be right there and you can see the person and have a conversation with the patient so that they can completely understand if they can't hear. Sometimes it's a person in the hospital who comes around to the site wherever you are, whichever department you're in, and can do the interpreting right there. And they're all trained, all these interpreters are trained in the medical language and speaking to people in a way that they can understand in their own language. Substance abuse patients, you're going to have to try to understand their level of cooperation and find a means of communication. And a lot of times the best thing to do with them is just to work quickly and efficiently and get as much as possible done with them as quickly as possible. These are the different age groups you're going to work with. You have to be sure, regardless of the person's age, how you're going to work with them and how you're going to deal with them. Geriatrics is another category that's not mentioned here, but it is on your master competency list, and there's 3 competencies on there that you have to get, and those would likely fall under the mature um, adults category here on this slide. So a lot of people don't agree. What does geriatric mean? At what age is that? So chronologically, they think maybe 65 is probably a good age to consider geriatric. Others say it depends on the patient's physical age. So you might be 55, but your body may have the mobility of a typical 75-year-old. So it really just depends on the patient's ability to get around. They might move slower, they might be unstable on their feet, they might appear to be frail or need a lot of help with moving around. And those people might be considered geriatric. On the other hand, they might be 90 with the spryness of a young 50-year-old. So regardless of how they present themselves, they all deserve your patience and respect. Pediatrics are definitely a challenging group to work with. It requires you as a tech to be aware of how you may come across to a child. Everyone is tall and scary to a child while they're in the hospital environment. And the first thing you need to do is set up your room before you even bring the patient in the room. Because if you're moving around and moving a lot of stuff, it's scary when the child doesn't understand what all of this equipment is for and what you're going to do to them. So if you have everything ready before you bring the child in the room, that's really helpful. Just make sure it's mostly inviting as much as you can be. I mean, not every place is a children's hospital, so you have to make sure it's as inviting as you can manage with what you've got. The shorter the time in the imaging room for the child, the better. So if you need immobilization devices, you're going to have to practice with those, and you're going to have to make sure you know how to use them well so the child isn't in it any longer than necessary. Have your technical factors all set up and film out everything ready to go so you can just do the exam quickly. And if you can do children, if you can image children and have only a few consequences from that, then you can really image anyone. When my son was 2, he had his tonsils out, and we went to Children's, and he was going to have the surgery. And we were talking to the anesthesiologist in a consultation room, and an OR nurse came in while we were in there, and she starts talking to Peter and picks him up, and they're walking around the room, they're looking at pictures and talking about the pictures. The next thing I know, they walk out of the room, and he was off to surgery without a peep, without a cry, with nothing. And I'll tell you, he was mad when he woke up, but he sure didn't act like anything was different when he left the room. There was not a single problem. And it's amazing when you have that kind of ability to work with children, you're going to have a much easier time, and they'll trust you and work with you. The next few slides represent so many physical changes that happen as we age, and you can look at this also on page 143 of your patient care book. Remember that just because we've slowed down physically doesn't mean that our minds are gone. Recognize this older person has been your age at some point, and in their head they probably still feel like they're 30 years old. But you have to be really careful in how you talk to them. Never talk down to them, and don't call them sweetie. People don't want to be called sweetie, honey, darling. They don't want to be called those things. They want you to speak to them as the human being that they are. So it's really condescending and patronizing when you talk to somebody like that. Even though you feel that and you're just expressing your care for them, that's not really how patients see it. When I was a student, we had a 90-year-old patient for a barium enema, and she was really tough to do. And I was working with a tech who was not very respectful to her as a person. So the patient was complaining after the exam while she was in the bathroom that she was miserable, and of course she was. Who wouldn't be? But the tech was completely dismissive of her feelings and her comments. And the old lady called her out on it, and she told the tech that she was rude and mean and shouldn't be allowed to work with the patients in the hospitals. And she was right. And I remember that was the first time that it struck me that these are people with feelings and a life outside of what they're going through at that moment. And it's not that you don't know this or realize this, of course you do, but I was finally seeing it from the patient's perspective. What if that was me or my grandmother or someone, and someone was treating me like that? It was intolerable. And when you get to that realization, you really see it for what it is, and you recognize that that is not how people should be treated. And that's where that understanding of respecting people, no matter what their situation is when they're in the hospital, has to come from inside of you, and recognizing it for what it is. You can't let your frustrations with the person or the situation show, because it's not your patient's fault. They are just trying to get through a very difficult situation. So above all, you need to be respectful and understanding of the current situation that they're in. And just like with anyone, you make eye contact, you speak clearly, and you make sure that they understand what you're talking about. You offer them blankets to keep them warm, ask permission to touch them. They're a different generation sometimes than you are, and they have to feel like you recognize them for what they are, and treat them with respect, and make sure they're comfortable. They're going to be so much more responsive and want to help you, help them. With terminal patients, it's a little bit more difficult. You're going to see death in the hospital. It can be sad and upsetting, but it helps to learn to keep it in perspective of the whole life cycle. Um, yeah, that you don't want to see somebody die, but unfortunately, they will, and sometimes it's difficult to keep yourself together in the face of these events. One of the reasons I could never go into radiation therapy was because many of the people that I met there were in the acceptance phase of their grieving process and their dying process, and they were so nice and they were so positive. And within a few weeks after I was there, I saw a couple of obituaries in the newspaper of some of the people that I had met there in that department, and it broke my heart. I couldn't separate doing the best thing as possible for the patient, and how sad it made me feel when they didn't survive their treatment. So that really wasn't the area for me, but for a lot of people, they can do that job. And it's fantastic that there are people out there that have that special ability to make people who are terminally ill feel good, about as good as they can about their care, and at the same time know that they're doing the best thing they can for that patient, and not letting it upset them to such a degree that they can't do their job if the patient dies. In some hospitals, they have signs that they put on doors of terminally ill patients, so that you're aware when you go in what the mood might be in that patient's room, with the family and the nursing care and the patient and all of that. So I think at Scripps it's a falling leaf, but I'm not sure, but I think that's what it is. So find out, learn what your hospital does to recognize patients that are terminally ill. The bottom line with the dying patients is to understand that they've made their choices and decisions about how they want their lives to end. And it's not up to you to judge that. And you have to accept it. Treat them as they request to be treated, and be respectful of their family members who might be with them. And then there's several stages of the grieving process. And most of the time you don't see the patient really long enough to know what stage they're really in, but the anger stage you're going to be pretty familiar with. You're going to recognize it right away. It's not about you, it's all about them, and they may take it out on you, but just remember, you can't change how they feel and how they're reacting to you. You just have to treat them with respect and get the exam done, and do the best you can for the patient. That's the best thing you can do. In conclusion, with this first part, communication skills are really essential in getting good imaging. And that's really up to you and how you treat your patients and get their cooperation. Hospitals will sometimes have a script for you to follow or to use when you're working with your patients because they're looking at patient satisfaction scores. And a lot of times they will expect you to let patients know if there's a delay so that they understand that you recognize they are waiting and you're trying to get them as quickly as you can. You just want to assure them that they're working the best way you can to make sure you get them in as quickly as possible. And if you have a patient in your room and there's a delay, you need to let the family members know out in the waiting area so that they don't worry as much. Communicating all of these things are really, really important wherever you're working so that the patients recognize that you understand what they're going through. And that's really the important thing. Eye contact, respect, treat people with dignity, respect their decisions and their choices, and be, the best person that you can be and caring, always caring for that patient. The next chapter, we're talking about taking the patient's history. So for our tech, what we really need to do is be sure that we get the information that the radiologist needs to get the best imaging possible for the patients that we're working on. Chief complaint, that's what we're looking for. And it has to be specific to the exam that you're doing. So you don't want the whole history of every surgery they ever had from, appendix to tonsils to whatever. If you're doing a chest x-ray, we're talking about what's going on with the chest. So these kinds of details it's going to be an important skill to learn, and how to take a history and how to keep the patient on track. So basically look at it as an interview of the patient. If you don't ask the right questions and see what the patient's trying to say to you, you're going to miss something. And then if you miss it, the radiologist is going to miss it, and diagnosis might be missed. So it's really important, a really essential skill and responsibility for a technologist to have. Be accurate and be specific. While the radiologist may have access to a patient's medical record, they are still going to rely on you to tell them the patient history. And this may be in tech notes in PACS, or you may directly speak with the radiologist about a patient's history. And the best way to do this is showing interest in what the patient's saying to you, being attentive, eye contact, respect, and just with everything, like everything we do with our patients. You are a caring person. That's why you're here in this field. So you need to show that to your patients so that they can trust you. Some of the qualities of an interviewer is really being a good listener is the key. If the patient's mad, then, acknowledge that. Don't just ignore it. Be genuine, be respectful, empathize, not sympathize with the patient's condition. Empathy, understanding that the patient is in this situation and you can empathize with them. But don't feel sorry for them. It's not the same thing. They need to feel like that the information they're providing you is important and that you're listening to them. Don't intimidate them. Don't just be attentive. Don't share your details or your history. Patients don't care what you went through. Your personal history will help you to be a better listener and a more empathetic listener, but it's really all about the patient. Be polite. Be professional. You can multitask, but not right away. I want you to figure out how to get a patient history, maintaining that eye contact and in conversation with the patient so they know you're listening, but don't be doing other things or turn your back on them, things like that. Once you figure out the good listening skills and taking the history skills, then you're going to be able to develop some multitasking skills as well. A lot of patients understand the importance of taking a history, but then you're going to get the ones who are going to say, I already told my doctor all of this. Look it up. It's all in the history. It's all in the notes. It's all in the, but you may be asking different questions that might not be in their chart, in the notes that they're talking about. So you can just explain to them, that may be, but I'm looking for specific things here, so I may need different answers than things that are in your chart. So, and I want to be thorough. You just have to be positive and let them know that, well, you have that information. You're looking for other kinds of information that are important in the specific exam that they're having. Don't ever disregard anything the patient's saying either, because it's not up to you to decide if it's important or if it's not important, or if it has anything to do with the patient's current issues. If it's a symptom that they have and they think it's pertinent, then it is, to them, it's very pertinent. So you write it down, you take note of it. Always ask an open-ended question that allows the patient to fill in an answer, or don't lead them to an answer or to a diagnosis, or you let the patient tell you what their symptoms are. You help them along by keeping it focused on the procedure that you're doing at the moment, so that you can get the answers specific to what you're doing for this exam. Repeat what the patient has said to you so that you can clarify it and confirm it. Also, when they give you a detail that's important, ask them more detailed questions about that, just to clarify things. I always like to say at the last minute, so this is what I heard. Did I leave anything out? Is there anything else you'd like to add? Because that way they know you've listened to them, and then you're giving them the opportunity in case they think you've glossed over something that was more important. It's patient control and patients feeling like they have some say, instead of being in a hospital with all control taken away from them, and that loss of running things for their own life. So you have to be aware of that and give them that power, that little, edge of power that they can at least hold on to while they're in this scary situation. What's the difference between objective data and subjective data that you're writing down on the history sheet? So objective is perceptible, measured, physiologic, signs that can be seen, felt, heard, and so on. Like, what is the blood pressure? Specific data. On subjective, that means that it can vary. Patient's feelings, the pain levels, attitude, opinion of the observer, things like that you are more subjective, meaning things that you perceive that might be going on, rather than the specific hard fact information that is objective. What's their pulse rate? What's their respirations? Something measured. Both of these types of information are very important. So what do radiologists want to know about the patient history? They want to know, what is the chief complaint? That's what they want to know. What is the patient's chief complaint that we're doing this exam for? So while you're collecting this information, you need to clarify it and hone it down to one chief complaint, and then the rest is just supplementary information. So why is the exam being done? That's really what they want to know. So the Sacred 7 medical histories, there's a table of this on page 148 in your patient care book, and it will help you with what kind of information you need to collect. If you're collecting a focused history specific to the procedure that is being performed, and that's what I was telling you a few minutes ago. So look at that chart on page 148, and you can see it breaks it down into each group of gastrointestinal or cardiac or, whatever area that you're looking in, and some suggestions of what kinds of questions to help the patient qualify their answers or focus their answers. In this instance, then, it's really important that you understand exactly the procedure that you're doing. And so the information that you're gathering from the patient is going to be specific to the procedure that you're doing, so the radiologist can make a good diagnosis. So if you're doing a chest x-ray, you want to talk about, are you having chest pain? Where are you feeling that chest pain? How long has it been? How have you been feeling it? And things like that are very specific. This is really important when you're going over the patient history considerations. Make sure you've identified the patient properly. And if you, for example, the order of the exam says left hand and the patient has a swollen right hand, are you doing the left hand or are you doing the right hand? You have to make sure that the thing that was ordered matches the symptoms that the patient has. So maybe the patient already had right hand x-rays and they do want a left hand because there are concerns of the left as well. Maybe they just ordered the wrong side and you need to get that corrected. Verify your symptoms with the exam request. That really falls to you to make sure that you have all the information correct. If there's a mistake along those lines, if you just say, "Oh, it ordered a chest x-ray even though their shoulder hurts, I'm just gonna do what they ordered." Don't be that person that's not thinking about what the request is for. If you verify, yeah, they do want a chest x-ray because this patient's going to have surgery, well, then that makes sense why they would do a chest x-ray and not a shoulder. Maybe the shoulder was already done in another exam. So anyway, you have to think about it when you're looking at it and talking to the patient. What is their history? What are they having done? Why are they having it done? To make sure the order is correct. And if you have any concern, then you either ask the radiologist or talk to the doctor who ordered it or the nurse that ordered it, because mistakes happen and it's up to us to try to catch them before the patient is not safe. Yep, keep reiterating, be a good listener, take notes, record them, get answers to key clinical questions, chief complaint, be professional, and you interact with the patient with respect and treating the patient with dignity in every aspect. So just remember, you are probably the eyes and ears and the voice of the radiologist with that patient. It's not likely that the radiologist ever really sees many of our patients that we have in the hospital unless they're having some interventional or cardiac studies and interventional procedures. But most of the time, it's you talking to the radiologist and the patient talking to you. So you have to get the information correct and be sure that you know what you're doing and what you're telling the radiologist is accurate. All right, good luck with this. This is going to be an ongoing learning process with patient care. So just let me know if you have any questions, and I will see you guys soon.